So to begin our first conversation, please welcome John Auerbach, who will moderate. He currently serves at CDC as its Associate Director for Policy and has spent decades addressing health disparities in Massachusetts at Northeastern University, at the State Department of Public Health, and the Boston Health Commission.
Auspicious day with a most distinguished panel who will be addressing an issue of continuing concern, namely disparities. So let me call up each of the members of this panel one by one. As I do, please come up and join me. First, I'm honored to introduce our Surgeon General, Dr. Vivek Murthy, who is, in the time he's been Surgeon General, has provided inspirational and really brilliant leadership. Dr. Murthy, please come up. Second, it's my pleasure to introduce Dr. David Satcher. Dr. Satcher is in fact a former Surgeon General, a former CDC Director, and former Assistant Secretary for Health. He's the current director of the Satcher Health Leadership Institute at Morehouse, and he is always a public health icon. And finally, let me introduce Dr. Rhonda Conerly Holliday. She is an associate professor of community health and preventive medicine at Morehouse, and she's a distinguished researcher that has looked at HIV, substance abuse disorders, and populations that are disproportionately at risk. Dr. Holliday, thank you for joining us. So I think it's a credit to the leadership of Director Brooks and the strategy that it focuses so strongly on the continuing need to address health disparities. And I'm going to begin with just a couple of remarks and then turn things over to each of our panelists. I'd note that in our discussion on the panel this morning, there's going to be a focus on racial and ethnic disparities with HIV, but it is, of course, worth noting that there are other disparities associated with HIV as well. Those related to poverty, those related to geography, related to sexual orientation and gender identification, and that those disparities also are very significant with regard to HIV, and in fact very often intersect with the disparities related to race and ethnicity. And undoubtedly, as we have the discussion with that focus on race and ethnicity, we'll be hearing about those other disparities as well. I think it's also worth noting at the beginning of the discussion that there has been significant opportunities that have been created by the administration to address disparities, and some have been mentioned, the ACA, but it's also worth noting the anti-discrimination policies of the administration, the focus on patient-centered medical homes with behavioral health components, the shifting of funding to those parts of the country where HIV has been, where the incidence has been greater. And these have all aimed to specifically reduce disparities, and we are seeing them reflected in the update as well. We're enormously grateful for those efforts, but of course there's always additional work that needs to be done. So our panel will be looking at where we've been with regard to disparities in HIV, where we are now, and perhaps most importantly, where we need to go. To begin, I'm going to ask each of our panelists, in the order that I introduce them, to offer a few opening remarks about their perspective on HIV and the relationship of HIV to addressing disparities. Dr. Murthy.
Well, thank you so much, Dr. Auerbach, and my thanks to all of you as well for your leadership on this issue, for your continued interest in ensuring that we make progress on what is a critical and essential public health matter. And I also wanted to especially thank Doug Brooks for his great leadership of the Office of HIV AIDS Policy at the White House. He's a great leader, an inspirational person, and I'm very glad that I got to know him recently as well. You know, I will say that HIV for me is not only a public health issue, but it's also an issue that has great personal relevance to my own story of how I got engaged in public health. When I was in grade school, actually, when I was in high school, I got interested in HIV because of the swirling stories in the news about how really fear-based stories, you know, of people worrying about whether HIV was, you know, in their communities, if they were at risk, worried about, you know, sharing space, utensils, anything with folks who may have HIV. And in that time of great fear, I found myself asking the question, what could I do to be of use, you know, with regard to HIV? And so when I was young, when I was actually later, a few years fast forwarded in college, my sister and I decided to start doing educational workshops in high schools and in colleges for youth, initially in India and then later in the United States. And the reason we started in India actually is on a summer vacation there, we realized that HIV was growing in terms of prevalence in India, but it didn't seem at that time that many people wanted to acknowledge that it was in fact there and on the rise, and we were very concerned about that. We were very young at the time. I was 17 years old, my sister was 18. We in many ways didn't know up from down when it came to launching public health initiatives, and we had certainly never built an operation before. But one of the wonderful things about being young and not having a lot of experience is that you don't know what you're not supposed to be able to do, so you just try it anyway. And that's what we did. And so when, you know, at that age, we built what became a nonprofit organization together focused on HIV education. And we had a series of really educational experiences, and we learned through trial and error. We learned by failing and by succeeding. But we would have these experiences where we would take students from the United States to schools and colleges in India, and we would talk to principals about letting us into their schools to talk to their girls and to their boys about HIV and about sexual education. And it was, on the face of it, a seemingly preposterous proposition that they would allow these young students to come in who didn't even grow up or live in their country, but allow us in to talk to their kids about sensitive topics. But we were able to convince them that either they had to or we had to, and they chose us because in many cases the topics were still at that point not of great, they were uncomfortable for a lot of people to discuss. So that's how I got my start in public health work. And what I realized through that experience working on HIV back then was that HIV was far more than a virus, but it was a social phenomenon, as many illnesses are, especially complex illnesses. One that was affected by people's beliefs, by culture, by fear, as well as by structural elements in a community which often impacted people's risk for acquiring infection, but also affected their likelihood of getting treated or not. I later came to see a different face of HIV as I got older, went through my medical training, and ultimately began practicing medicine. And during my time practicing in Boston, I had the great privilege of caring for many patients who had HIV and who advanced to the point of having AIDS. And what I learned was a great deal during that time about personal stories of hardship and sadness. And I also came to see firsthand how HIV disproportionately impacts certain communities you know, in our country, particularly the poor, but also with the bias based on gender, based on race and ethnicity. And those were very evident to me, even in my small n, in terms of my own clinical practice. So that stuck with me as well. And what struck me often is that if I had been in the same socioeconomic circumstances as many of the patients I was treating, that I would have been at much higher risk than I had been growing up in what was a relatively comfortable background for much of my life. So these lessons stuck with me. But as I reflect back on the last several decades, since I started getting involved with HIV until where we are now, what heartens me is the extraordinary progress we made. I remember when we began our programs, my sister and I, HIV was really looked at as a death sentence. And thanks to some extraordinary scientific advances that we've made over the last few decades, many people can live full, wholesome lives with HIV if they have the right support and if they have the right treatment. And we also have made great strides when it comes to education. So where in many cases we've been able to replace unfounded fears with more sober, informed knowledge of what HIV is, how it's transmitted, and how to protect oneself. We haven't done that universally, and clearly there's still a great deal of fear and misunderstanding about HIV. I would say there's also a fair amount of nonchalance, I should say, about HIV, where we have, especially in our younger generation, people who don't remember what the 80s were like because they weren't alive then, and they have forgotten just how serious an illness HIV can be and how important it is to be safe and to get tested. And so for the younger generation, we find ourselves having to redouble our efforts at education, but also to approach it in a slightly different way. So we have made a great deal of progress, and I'm particularly proud of the global progress that we've made and the role that the United States has played as a global leader to assist so many other countries around the world in not only bringing more education to their communities, but really assisting in extending treatment to populations which otherwise would not have had the treatment that they need and they deserve. So great progress has been made, but as we're here to discuss today, there's also much more progress that needs to be had. We still have great disparities when it comes to HIV, particularly on racial and ethnic lines, as I and many of us in this room have seen. We also are in a situation where, as I mentioned earlier, we recognize that education still has a long way to go, where we have many folks, and youth in particular, nearly 50% of people who have HIV don't know that they're infected because they don't get tested, because they don't think to get tested, and in some cases they don't have the ability or access to the care they need. So we have much more work that we have to do, which is why the update to the strategy is so important. The vision that Doug outlined for the strategy, that of making new infections rare and ensuring that everyone, regardless of their background, has access to high quality care, that is an essential piece of that vision and an essential goal that we need to continue to work toward over the coming years. And I will lastly say this, that working on this and redoubling our efforts is actually more than about disparities. It's actually even more than about just HIV, but it's about a fundamental question of national character and values. The question that I think of in my mind is, are we a nation that fundamentally believes that every person should have access to high quality care? Are we a nation that believes that every man, woman, and child should have a shot at good health? I believe the answer to that question is yes. And if the answer is indeed yes, then that means that tolerating disparities in HIV in particular is antithetical to our values. And so the efforts that we are recommitting ourselves to today are about disparities, they're about HIV, but they're about who we are fundamentally as a country and what our values are. And through the efforts that we make, I believe that we can reassert that the values that we live by and stand by are ones that are premised on equality for everyone, regardless of where you're from or regardless of what you look like. So that's why I'm very grateful for the work that has been done on the strategy. I'm eager for our discussion today and for the discussion that's going to take place over the rest of this program's agenda. And I finally just want to thank all of you again for being leaders in this effort, for committing yourselves, and in many cases, much of your lives and careers, to this incredibly important issue. And I know it's an issue that has received a lot of attention at some times and not so much attention at other times, but it's because of people like all of you who continue to work hard and to make sure that we are moving the needle forward. That's why we're at the place that we are today, having made great progress and ready to make even more progress in the years ahead. Thank you very much.
Thank you for those thoughtful comments. And Dr. Satcher.
Well, thank you. Let me just join our president and others who have welcomed you today to the Morehouse School of Medicine. We're delighted to be able to be involved in hosting this very important event. I want to begin by, in addition to welcoming Surgeon General Murthy to the Morehouse School of Medicine, I want to say amen to everything he said. Not only will that save time, it will significantly elevate my discourse. But seriously, I'm very pleased to be here with Surgeon General Murthy. I was at his swearing in. I've had an opportunity to visit with him in his office. He's visited us here before. And I have to tell you, I'm just deeply impressed. And the office of Surgeon General means a lot to me. And I'm just so pleased that he is taking it to new heights in terms of his personal attitude and his listening to people throughout the country. And even though we've made a lot of progress with HIV/AIDS in terms of the science and the knowledge in terms of treatment, we still have a long ways to go in terms of our attitudes and relationships that I think are so critical to getting this disease under control. And I hope we can continue to make progress in that arena. But I think it's the attitude that the Surgeon General has communicated that's going to be really important for the future. Now, yesterday, President Valerie Montgomery Rice and I were at the Carter Center, and we were there in celebration of the 50th anniversary of Medicare and Medicaid. And today is actually the day of the 50th anniversary. We got a little bit of a jump on it. But I want to say, and they asked me to talk about the way it was before. You know, I'm getting to that age where people always want me to talk about the history, and I'm delighted to do that. But seriously, when you think about it, and I believe then Senator and Vice President Humphrey probably stated it best, and I remember Secretary Shalala, when we celebrated the 35th anniversary of Medicare and Medicaid, quoting Senator Humphrey. So you may remember, he said that the moral test of a government is, one, how we treat people in the dawn of life, our children, how we treat people in the twilight of life, our elderly, and finally, how we treat people in the shadows of life, people who are suffering from illness, such as HIV/AIDS. How do we treat people in the shadows of life when they're struggling to achieve and maintain good health? It's the moral test of a government, it's the moral test of a people. And I think we face that test today. I want to say a word about the Satcher Health Leadership Institute at the Morehouse School of Medicine, and what we are trying to do in the context of the mission of the Morehouse School of Medicine. Our mission specifically is about helping to develop leadership, especially leadership among those who are committed to the reduction and ultimate elimination of disparities in health. And when we talk about disparities, as you sort of heard earlier, we're not just concerned about race and ethnicity. We're concerned about the disparities that we see in the way people with mental disorders are treated or not treated in this country. The disparities that we see in the way that we treat people that we may consider to be in the sexual minorities of this country. There are major disparities in attitudes and delivery of services. And that's what we're trying to overcome, and I'm deeply grateful for this new strategy that we're going to embark upon together to get closer to that. Usually every year, the first week or two of August, I speak to the new students at Spelman and Morehouse. I've been doing that for 10 years, but they're blessed because I think Dr. Montgomery Rice is going to do that this year. But I've always felt very deeply about those students and what they were embarking upon in terms of their college careers. and all of the challenges that we all face. And I've always spent time talking about HIV/AIDS. But I think we do owe it to our young people especially, as they deal with many issues related to sexuality. We owe them the kind of leadership that we have not often provided. So I'm hoping that that kind of leadership will be real. The next point I want to make is about leadership, of course, is that I think we've got to help to find and develop the leadership in the communities themselves that are most impacted by this disease. Now, we have a health policy leadership program. Most of the people in that program are health professionals or people in public health or clinical psychology or psychology. But we also have a community health leadership program that we're very proud of. We invite community organizations to recommend people to come and spend 12 weeks or this equivalent with us, really together studying health promotion and disease prevention. And I really want to emphasize together, our philosophy is that at this institute, everybody teaches and everybody learns. And I can tell you that we've learned a lot from the people who come here as students. But I believe that we're going to have to help to identify and develop the leadership in the community and then support that leadership if we're going to ever solve this problem. And that's what we're trying to do. But I think the most important leaders were the people who marched across this stage on Saturday as we graduated our 5th class of parents. We have a leadership development program for parents, which we call Smart and Secure Children. We started that program a little over 5 years ago, and now we've been funded to replicate it in 12 states. But we believe that parents are probably the most important leaders, and that if we can help parents who really care deeply about their children, many of them single parents, 80% of the parents in our program are single parents, but they care about their children. And what we're trying to do is to provide them the support to be the kind of parents that we know they want to be and that they can be. And again, we're learning a lot from them about how we can do what we do better, and hopefully in the future partner with them as we try to implement community programs. So that's what we're trying to do in terms of leadership development, and I hope you will continue to support us in that regard. We believe that in order to eliminate disparities in health and achieve health equity, we need leaders who first care enough. Then we need leaders who know enough, leaders who have the courage to do enough, and finally, leaders who will persevere until the job is done. And I hope that together we will provide that leadership for implementing this new national HIV/AIDS strategy. Thank you.
Thank you very much, Dr. Satcher. And now, Dr. Holliday.
Okay.
Forward to your comments.
Let me move the mic. I usually have this problem when I stand at the podium. I think I would have this problem sitting down. I'm a little short. Okay. First, I would like to, again, welcome you all to Morehouse School of Medicine. It's definitely a pleasure to have you all here, as well as it's a pleasure to serve on this panel. As a behavioral researcher, my work is really focused on finding ways that we can change behavior to prevent infection with HIV. And as you know, behavioral change is not easy. It's something that's difficult. If we think about what things that we need to change our behavior, I'm sure that all of us have tried to exercise more or eat better. Those things are hard. And it's the same with HIV. It is not easy to change behavior, but that doesn't mean that the work should stop. It has to be done. I work with our Prevention Research Center, and one of the things that I have come to learn over the last few years is the importance of community, and piggybacking off of what Dr. Satcher said. The communities that I have had the opportunity to work with are very concerned about HIV. It is always one of their top health concerns within their communities. They want to know, what can we do to stop this particular disease from ravaging our communities? And those of us in Atlanta know all too well that we have some of the highest HIV rates in the country. And so when we're thinking about disparities, I think it's very important that we go into the communities and that we bring the communities into our work in trying to figure out how to reach people, how to educate people, how do we get people tested. And if we don't involve the community, then our efforts are not going to be as successful as they should be. And so I just wanted to leave you all with just that thought of making sure that the community is involved at every level. They can identify those issues that are important to them, because there are other issues besides HIV that are important to them that they need to have addressed as well. And so if we can think about some of those structural issues that they identify, it can also help us in our work as we work to combat HIV. Thank you.
So, a terrific panel, and now it's my pleasure to actually maybe ask a question or two of each of you about this topic. And Dr. Murthy, I'd like to start with you. And I appreciate you sharing with us that you've worked on the issue of HIV for a long time and really thought a lot about it. And I know that in your tenure as Surgeon General, you've traversed the country and you've gone to lots of meetings and had a chance to talk to people about HIV and other health issues. And so I guess I would maybe just start by asking you, when you consider HIV in the context of disparities and health in the country, what are your greatest concerns at this point?
Good question. Well, earlier today we touched on some of the disparities that concern us. We talked about some of the persistent racial and ethnic disparities with HIV. We talked a little bit about age, and one of the things that concerns me is that if you look at youth, particularly like populations from 13 to 24, while they make up around 17% of our population, they represent around 26% of new infections, and that's concerning to me. There's also a knowledge gap that concerns me as well, which is that when we look at the youth, for example, who are in that 13 to 24 age category, that 50% of them who are actually infected don't know that they are infected. That knowledge gap is also of great concern to me, not only because it has an impact on their health, but because it has an impact on the health of other people around them who they may be putting at risk. So these are some of the things that concern me. And I should say also that the other element that concerns me is that the root of these disparities is complex. It's not one single thing. It's not that we don't have enough hospitals in one community or that we don't have enough doctors or nurses in another community. But it's very deeply entrenched, I think, in the complex web that makes up communities, and it's linked and often to poverty as well. And addressing poverty is not, as all of us know, a simple one-shot solution. Addressing beliefs and attitudes, as Dr. Satcher said, is another element that's at the root, of disparities. But that also is not simple. Sometimes, as I've traveled the country, as Dr. Auerbach mentioned, I started my tenure doing a listening tour, where I went to small towns and big cities all across America to understand directly from people what they were worried about, but also to learn about what innovations and creative ideas people were implementing in their communities. And what I heard about, I heard about many things as I traveled, but I heard about HIV quite a lot as well. I heard concerns from people that younger community members had stopped worrying about HIV and weren't concerned as much about transmission. But I also heard that there were still persistent negative attitudes towards HIV and people who had HIV that prevented many people from coming forward and getting tested or getting the care they needed, even if they did test positive. So changing these attitudes is not something that one can do simply through regulation or legislation. But changing culture is really rooted in what local leaders do and say. For example, often it's what perhaps our parents say at home that might influence us when we're young, perhaps even when we're older. It's what we hear from our employers, from the faith leaders we trust, from trusted community leaders, like Dr. Satcher, for example. Like these are the kind of individuals and institutions who can often shape the beliefs and the attitudes of people on the ground. And that's why I believe if we are really going to address disparities, we not only have to ensure that we are taking a policy approach, for example, expanding access to care as the ACA has done, but we also have to make sure that we are building a movement on the ground within communities to shift attitudes and to influence how people think about this. So it's not just some foreign virus or condition that other people have, but it's something that affects our communities, our neighbors, and an issue that we have to come to grips with and address. I'll lastly say that I think that there are a couple of opportunities for us here, which is that while we recognize that there are disparities, we also now have more and more data about where those disparities exist, which enables us then to target our efforts and to ensure that we are not just taking a scattershot approach to treatment or education or to services, but that we are really targeting those assets in the areas of greatest need and to the populations of greatest need. That data we have in much greater abundance now than we had 20, 30 years ago. And so the question is, can we use that data effectively to target our efforts? The second opportunity I see is one related to technology. And that's that with new technology, we also have new opportunities to communicate to people in ways that are very new. And what we know is that 20, 30 years ago, the way people got their information is very different from how people get it now. In 2015, not everybody reads the same few newspapers or watches the same few news channels. Many people don't watch the news or read the newspaper at all, in fact, and they get their information from other sources, whether it's friends, whether it's social media, whether it's niche blogs. But the explosion in communication technology also gives us an opportunity to reach more people if we are able and willing to harness that technology and use it in creative and thoughtful ways. And I think we've seen examples of how that's been done on health in the past. And I think we have a great opportunity to use both technology and data to really address disparities now.
Thank you. Thank you very much for that, those insights. Dr. Satcher, maybe I'll ask you your thoughts. You have dedicated so much of your professional life to improving health policies and to focusing on disparities, but you've also often used the positions that you've been in to look at some health issues that have been neglected, maybe not focused on as much, and those include issues like behavioral health, and they include sexual health. And so I wonder if you could share with us your insights with regard to disparities in HIV and the way that they particularly manifest themselves with regard to behavioral health and sexual health.
Well, I was thinking about when we released that first Surgeon General's report on mental health, and that was before we knew we should be calling it behavioral health. And I agree that's broader, because right now here at the Morehouse School of Medicine we have a partnership with the Kennedy Forum. Patrick Kennedy and I worked together on that first report and have worked together since. But so that partnership creates the Morehouse Center on Mental Health, Addiction, Policy, and Research. And Patrick and I have been going around the country talking about, number one, what the Affordable Care Act provides in terms of opportunities, as never before, really, for people with mental disorders to gain access to quality mental health services. But it's not going to happen unless we work very hard to implement it and to really motivate people to seek care, but also motivate insurance companies and providers to be there providing that care. I think that's critical. I don't believe that we're going to be very successful in reaching our goals with HIV/AIDS or health in general unless we pay much more attention to the behavioral health needs of individuals and families and communities. Even when you talk about the issue of Black Lives Matter, I don't know if you've thought about the fact that to what extent do we really think about the mental health of policemen before they become policemen? And to what extent are we as a nation really taking seriously the need for people to be behaviorally healthy before we give them a gun? And I think we've got to do that. We've got to take that very seriously. Thank you. So we take mental health very seriously in our institute and this institution because we believe that it's really a critical part of eliminating disparities in health and achieving health equity. Not necessarily, as we said in our report on mental health, culture, race, and ethnicity, not necessarily because any minority group has a greater prevalence of mental disorders, but a greater burden of mental disorders, the burden that comes with mental disorders. And I think in the area of sexual health, I think most of you know, of all of the reports that I had the opportunity to release, the most difficult one was the one on sexual health. And that difficulty pervaded two administrations, the Clinton administration and the Bush administration. People were not ready for a report on sexual health. And so we had to fight and we had to scheme and everything to finally get that report out in the Bush administration. You know, President Bush asked me to stay on and complete my term when he became president because I thought he would want me to leave, and I only had a year left. But it was in that last year that we were able to complete the report on sexual health. By the time we completed it, they were ready for me to go, of course. But seriously, I think the issue of human sexuality and sexual health is one that we have not been able to come to grips with in this country. And until we do, we're not going to solve this problem. We're not going to be successful. And the same thing, of course, is true with addiction. Before I left the CDC to go to Washington, we had just completed what I consider to be a really great study, 36 sites. We had been asking the question, if we provide people with addictive disorders with clean, safe syringes and needles, what impact would that have on this epidemic? And what impact would it have on their addiction? And those studies showed unequivocally that by having the availability of clean needles and syringes, we would reduce the spread of HIV/AIDS and not increase drug use. In fact, many of the people, because of the availability of that service, went into treatment programs for their addictive disorders. And yet as a nation, our attitudes are still not ready to say that people who have addictive disorders need help more than punishment. And so we got to figure out a way to provide the help and not depend on punishment. Probably more than you wanted me to say, I'm sorry.
Exactly what I wanted. Delighted. Dr. Holliday, you're a distinguished researcher and you've been involved in studies funded by NIH and CDC that have looked at HIV and substance abuse disorders, including alcohol abuse, and incarcerated populations. Mm-hmm. And so clearly you've thought a lot about that. And I wonder if you could share with us what the research bears out on that intersection between HIV, alcohol and other drug use, and incarceration, and especially whether we are seeing variation in the impact on different racial and ethnic groups.
Mm-hmm. Well, when we think about incarcerated populations, and honestly many of us don't think about incarcerated populations because they've obviously done something to deserve to be in jail or prison. I hear that all the time. But when we really think about incarcerated populations and we think about communities that are disproportionately affected by HIV, a lot of those populations are inside jails and prisons. So we think about those race and ethnicity differences. We think about people who may have mental health issues. When we think about sexual orientation, all of those factors and people are present inside our jails and prisons in this country. And so when looking at HIV in our correctional facilities. One, we know that African Americans and Latinos are disproportionately affected by HIV. We know that African Americans and Latinos are also disproportionately incarcerated, and particularly when we look at males, and this is across adolescent and adult population. What is interesting is that substance use, which has placed a lot of people in prisons over the last few decades, is not disproportionate. When we look at the numbers by race and ethnicity, it's not disproportionate. In fact, many times African Americans, Latinos have lower rates, but they are incarcerated at higher rates for these same issues. Some of that is from the war on drugs, targeting certain communities, looking at those structural factors. And then we also know that injection drug use is a risk factor for HIV transmission. In the populations that I've had the opportunity to work with, alcohol and marijuana tend to be the substances of choice. And so when we think about HIV transmission, we don't necessarily always think about those substances. But what research has demonstrated is that particularly for African American and Latinos, is that the use of alcohol and marijuana can also increase engagement in risky sexual behaviors such as multiple partners and sex without condoms. So it's important that we look at alcohol and marijuana as drugs that may increase the engagement in risky sexual behavior. Also, when we think about incarcerated populations, so they're inside a jail or prison. They're not supposed to engage in sex. They're not supposed to engage in drug use. And the research has shown that those behaviors do actually decrease inside the facility. But the important thing to note is that when they do engage in those behaviors, they tend to be riskier. So do you think they have access to clean needles or whatever they're using to inject drugs, or even tattooing one another? If they engage in sexual behaviors, they most certainly, I would say the vast majority of correctional facilities do not have access to condoms. We know sexual activity is taking place, but condoms are not made available to people who are incarcerated. Some of my research that I've also done has, again, demonstrated that with jail detainees, and jails are a little bit different than prisons. A lot of people get those two mixed up. But jails, people are in there for a shorter period of time. There's a high turnover. But with an adult male jail population, what we found when we did a behavioral intervention with them is that we were able to increase their use of condoms during sex at the 6-month period. So we were very pleased with that. And then finally, the last thing that I'd like to talk about is a lot of my work has shifted to not just what happens inside the facility and working with people when they're incarcerated, but also what happens once they leave, because they leave. They're not going to be in jail or prison for the rest of their lives, the majority of individuals. And so it's important to realize that many of those structural factors that existed prior to incarceration, such as poverty, homelessness, discrimination, access to health care, are still present once they return. And not only are they present, but they're often exacerbated because of the stigma of incarceration. There are laws that prevent access to housing based on convictions that you may have had, laws that prevent access to certain types of employment. So there are many things that we have to consider once these incarcerated populations return to the community, that it just doesn't stop once they are released, but then there's that whole process of community reentry. How do we sustain them and provide them the services that they need once they are released? For one, that they'll have optimal health, 2, be fully functional in society, and 3, will not recidivate and go back into a facility. So those are some issues with that.
I'm sure I speak on behalf of everyone in the audience to say we could spend all day talking to the three of you. You have so much to offer. given the constraints in terms of time and the other panels, I want to ask each of you just one additional question, relatively brief question about what might be a way of suggesting a direction for the future. And to start with you, Dr. Murthy, you know, I know that you've thought a lot as well, in addition to the work you've done on HIV. You're a co-founder and former president of Doctors of America, you know, a nonprofit that's worked with thousands of physicians and medical students on ways of improving health in the country and focusing on access and high quality care. So I know you've thought about training a lot. What's your sense about where we are in terms of clinical and public health training with regard to the issues associated with HIV and disparities? Have we made improvement? Is that an area that needs additional attention?
So this is a great question, and one that I have thought about because I spent the last 6 or 7 years working with physicians and medical students across the country and working to engage them in the process of improving health and health care in their communities. You know, I think that compared to 20, 30 years ago, obviously the care of folks with HIV and the prevention of HIV transmission has made major strides, but has also become more complex. And so there is more for medical students to learn, for example, as they're training. There's more in the way of continuing medical education for physicians and nurses to keep learning, you know, even though they may have finished their formal training some years ago. And this additional knowledge and training that has to be delivered and transmitted, I think creates some challenges. I think that there are some training programs which have done a great job of integrating both the medical care and the social aspects and cultural elements related to HIV into their curriculum. But I think that this is not done consistently and in the best possible way at all institutions. I think also similarly with training, with postgraduate training or what's called residency and internship and fellowship training, there too, the care of people with HIV has become increasingly specialized. And so folks who are training in general internal medicine and family practice, the training that they receive in how to care for people with HIV also is really good in some institutions, but variable, really across the board. But there are, I think, there are two key areas where we need to explore further when it comes to training our clinicians. In addition to ensuring that they are well-versed in how to provide good clinical care, I think that there are two other things that we have to do. One is recognizing that HIV is not something, your outcomes are not just determined by whether you get to see a doctor or not, but they're determined by many things that happen in your community. For example, how connected you are to social services. They're also impacted by really, you know, in a sense, from an education standpoint, what you're hearing or not hearing from the institutions that you respect and value. And we know that there are other factors like housing, for example, and poverty, which have significant impacts on people's ability to stay a part of a treatment program, and that also impact their risk as well for acquiring HIV. Given all of that, if we want clinicians to be part of the overall solution, they have to also be trained to understand the community factors that impact HIV, and they also have to know how they can be a part of strengthening that complex web of interconnected services and factors that needs to be in place to really ensure that we are treating people in the best way possible and also preventing new infections as best we can. Now, this idea of moving clinicians to a place where they're thinking about public health and community health, this is one that's been talked about for a long time, but that hasn't always been successful. When you talk to folks in medical schools, they'll often say, our curriculums are really packed and burdened as it is. Where do you want us to slate in something about community prevention? But this is about more than allocating a few hours a week in a curriculum. It's more about a mindset change that we have to bring to how we think about the role of clinicians. Clinicians, I think, the last several decades their role has primarily been in a clinic or a hospital to think about when a patient comes in, my goal is to engage with them there, and after they leave, hopefully somebody else can pick up, and provide the assistance and support that they need. And often, and I'll say this, somebody who until very recently was practicing up in Boston, and who trained up in Boston as well at a very good hospital. But I will say that even for me, when I was going through my training, I didn't have a great sense of what happened to my patients in between visits. You know, I didn't know, like I didn't visit their home, so I didn't know how difficult it was for them to follow some of the advice that I was suggesting. I didn't know what neighborhoods they lived in. So telling somebody to go for a walk after dinner to assist with weight loss might be easy if you lived in a safe part of town, but if doing that put you at risk of getting mugged or shot, then you just weren't going to do it. Understanding really the context in which people live is something that increasingly has become, I think, harder for clinicians as they've gotten more specialized, more anchored to clinics and hospitals, and more disconnected from the communities in which people live. We have to somehow bridge that divide again, reconnect clinicians with their communities, and help them understand the role they can play in essentially creating a seamless structure of services that runs between the clinic and the community. If we do that, then I think that we can make clinicians part of the solution even more so than they are now. And we can also actually reduce a lot of frustration, I think, that clinicians have. Because, you know, most clinicians aren't dumb, right? And they realize that there are other factors outside the clinic that are impacting their patients' care, but they often feel like they don't have the ability to control that or influence or contribute to it in a meaningful way. And this happens all the time with, for example, talking about weight loss, right? When you try to talk to somebody in your clinic about changing their diet, about exercising more, and you know it's going to take a whole lot more than you just telling somebody, you know, at a clinic visit once, you know, every couple of months for them to really change. But you're not really sure how to be a part of all of those things that are happening between visits. So I think if we can build that connection more closely, help train and integrate clinicians into the community services that are taking place, we can do better. And one last thing I'll just add very quickly, the second factor, which is around communication, which is that clinicians have an extraordinary opportunity to communicate and influence patients when it comes to behaviors. And that varies depending on the bond of trust that's built, for sure. But it also varies based on the ability of clinicians to effectively communicate with their patients about behavior change. And you know, as many of you may know, if you are clinicians or if you've been on the other side of the table working with a clinician, you know that there are certain things clinicians can do which may be more effective in reaching you than others. And this is particularly important right now because in an age where we have so much information on the internet, so much information that's disseminated through social media, the challenge has become distinguishing what's true and what's false, right? And we live in an age where a single article, which is claims to be a scientific study, but which is ultimately found to be fraudulent, can convince people still, years after the fact, that the measles vaccine still causes autism. And we all know that that is not true, that it's not founded on any evidence that's been disproven by many studies. But I still get messages and hear from so many people in communities who cite that study and who hear from others that that was actually true. And so this raises the ante and the importance of training clinicians in particular about how to communicate effectively with not just the patient in front of them, but with their communities that are well beyond their clinics. Because if we can recruit and train our clinicians to be effective communicators, to help people understand what we know in terms of the science, then whether it's about getting vaccinated, whether it's about needle exchanges, whether it's about HIV prevention, then we will have far better tools and an ability to get people the information that they need.
Well, let me continue then that stream of thought, and Dr. Holliday, ask for your thoughts about the notion of training, developing pipelines for new people, perhaps people of color, people whose backgrounds are in poverty, to enter the workforce and have opportunities to become researchers, for example, following in your footsteps. The updated strategy does in fact point to that as being an important step necessary if we're going to be grappling with disparities and promoting health equity. You've served, I think, on a national committee that's looked at that issue, and I wonder if you could share with us your thoughts about it.
Sure. Pipeline programs are near and dear to my heart because I am a product of several pipeline programs. Starting in undergraduate, when I right after graduating from high school, it came to my college campus, which is here in the Atlanta University Center, and began researching in one of our psychology labs. And what that did for me was to expose me to a field that I did not know existed. I had a vague idea of what I wanted to do, but the whole area of research really was not on my radar. It hadn't been something that I was that I had had the experience and exposure to. So pipeline programs, I think, are extremely important. So I've had the opportunity to not only serve as a participant in a pipeline program, but also to serve as a mentor in several pipeline programs, as well as serve as a co-director for a program that was funded by NIMH. And these programs, I really can't say enough about these programs and the importance of these programs in exposing students, particularly minority students and first-generation college students, which I was as well, to the possibilities and opportunities that exist for them. And these programs, I think, are essential to diversifying our public health workforce. So not only programs, I think, at universities, but also getting the community involved, working with community-based organizations so that our future public health workers can go in the community and see some of the issues that are affecting communities and figure out how to work with those communities. You know, some of the students that I've had the opportunity to mentor have gone on to MPH programs, have gone on to PhD programs, into medical schools. And I can say that for all of them, these programs have greatly impacted them and influenced their trajectory. One other thing with pipeline programs, faculty involvement is very important. I know sometimes we have to pull faculty in because we're all very busy, but faculty involvement is so very important. Students learn so much from just being around faculty. And then funding as well. Funding is always crucial for these programs. There have been some cuts in programs, and then some funders sometimes specifically want to see the outcomes as it relates to their specific field. And one thing that I would say is that students don't always go into a narrow defined field as provided by the funding agency. But that doesn't mean that the work that they do will not have an impact on the issues that the funding agency is interested in. So I would encourage funding agencies to, one, maybe not be so narrow in their focus, but also recognize that the people that are being trained through these programs are actually working on issues that have a great impact on health in general.
So much, and well, I'm going to turn to you, Dr. Satcher, as our still youthful elder statesman today, to maybe add your comments when we think about the future. You're heading up the Leadership Institute. I know you think about the future, and maybe you could share with us your thoughts about what kind of leadership training is necessary if we're going to be eliminating these disparities.
Well, first, let me say, I think leadership is critical. I think it was the Institute of Medicine's report of 1988 on the future of public health, and one of the statements that stand out and that we referred to was the statement that we cannot expect the emergence of leaders by chance alone, that we have to become intentional in supporting the development of leaders. I think it's critical. But I also think it's critical because when Dr. Murthy describes what's needed, it's going to take a lot of new leadership to bring that about. If you just take the social determinants of health, and as he's described so well, I had the opportunity after leaving government, our government, to work for 5 years with the World Health Organization on putting together this report on social determinants of health. And I think it's really critical that we find a way to really better target the social determinants. Physicians have to see themselves as members of teams because we don't have the knowledge and the skills that are often needed to make sure that the social factors that are so critical to how patients present and respond is taken into consideration. So I just think we need new leadership, we need new curricula, and all of those things that will move us to a new place in dealing with these issues. So I think the Affordable Care Act provides some tremendous opportunities. Discussing the issue of needing more primary care providers. The Affordable Care Act attempts to incentivize primary care as we've never seen it incentivized before, rewarding family physicians, rewarding people for serving in underserved communities. But what's often missed in the Affordable Care Act is a prevention agenda that says, really, we're going to provide a way to support communities in putting together programs for prevention. That we've never done that, and we may not be able to do it this time because Congress keeps taking the money out of the budget to fund the prevention agenda. And I know, Vivek, that you served on that council that put together that prevention agenda. And it's critical that we follow through on that, and we have not. And so I'm going to close with that. I just think we have some tremendous opportunities, in part due to the Affordable Care Act and some of the work around it, but opportunities whose time have come.
Well, thank you, and thank you. Please join me in thanking this extraordinary panel.